call upon Dr. Bipinsethi to talk to us on non-surgical options for size reduction in multinodular goiters and thyroid.
Thank you, sir. My job is to speak on the non-surgical management of multinodular goiter and thyroid nodules. We will start off with a patient who is come by having noticed nodule when he took his son for malaria. He had no symptoms, particularly of pressure, hypo, or hand function. Now, in this situation, what are the tests that you're going to do? You will obviously try to see whether this is associated with thyroid dysfunction. You will also look at ultrasound. Previously, when I was a student, my boss used to say, what is there to do by way of ultrasound? I can see the nodule, but there are a lot of characteristics in the nodule which make you know whether this is having a potential for malignancy or not, and this is almost as good as FNAC, and sometimes it might tell you whether FNAC is required or not. Specifically, if the nodule is truly cystic, you may not aspirate even nodules greater than or less than 15 millimeters. Usually we aspirate all nodules which are 1 centimeter or more. And if the TS is suppressed, that is possibly the only valid indication apart from diagnosing thyroiditis in the current day for an isotope scan to know whether there is an autonomously functioning nodule. So the therapy will obviously depend on the findings of these investigations, and functionality is largely going to determine this. If it is a benign nodule on ultrasound and also by aspiration, this is where my discussion is about, and if it is functioning, there can be differences between surgeons and endocrinologists. There has been a study which showed that if a functioning nodule is given to endocrine surgeons versus endocrinologists, 65% of endocrinologists would give radioactive ablation, whereas about 67% of surgeons will try to do surgery. So it depends on where the lady goes with her hair. If she goes to the hairstylist, he will put it nicely. If she goes to Tirupati or Bipinsethi. So then it is Robert Frost who said that there are 2 roads and you take one of them and that makes all the difference. But there are 2 areas here. Either you do nothing or you do something, and I come from what was originally Andhra Pradesh, and there is a 3rd road, and I am going to traverse the 3rd road for you. The references I have are from the textbook of Bailey and Lau, which all of us studied as students, which says that anything that is thyroid must be removed. And then Alice in Wonderland, then obviously there will be some less scientific guidelines, the ACE guidelines and AHA guidelines. I think all of you know this picture, where this Queen of Hearts says, off with their heads, off with their heads. If the patient goes to a surgeon, there is no one going to come out of that room without having the thyroid removed. If my patients are to believe, they are asked to get admitted by today evening so that tomorrow morning surgery can be done. So most thyroid nodules are benign and they do not need surgery. Unfortunately, visible nodule can be seen, and patient is often reminded about the neglect and its consequences by so-called well-wishers in the marriages, birthday parties and things like that. And most often than not, they get it removed, but unfortunately issues are not just financial. You could end up damaging the enabling structure if not living a nice lifelong scar. If the nodule is truly big, if it is causing cosmetic disfigurement, if it is putting pressure on airways, esophagus, nerves, then obviously there is an indication as to surgery being done. You might wonder how big is the goiter, because any goiter, if it is said that big, then that means it's a very subjective criteria. Hyperfunction, I told you, requires treatment, but depends on where you go. If you go to the endocrinologist and say radioablation is good, if you go to a surgeon, he says you get surgery done. The patient is scared about cancer. Depends on who put the fear in her. Is it the surgeon or physician, or was the patient scared of the procedure? And patient preference. Many times patients come to us saying that my doctor said that there is a chance of cancer, the cancer may develop, and what is there in our language is that the structures in the body of plant which are to become thorns are sharp from the very beginning. So it is not that you're going to have cancer 20 years down the line. So many times we jocularly tell our patients, did you have an appendix removed? Why are you asking that question? I said, it might burst when you're going to San Francisco from Dubai, and that's a dangerous condition. So you might get it up, and that can actually happen. But the conversion of a nodule, which has been nicely studied on ultrasound and also biopsy, is much, much less. It is not that after 5 years it will become cancerous, 10 years it will become cancerous. So it is true that we have to rule out malignancy. I am not talking about leaving all nodules alone, but you have to have ultrasonography, you have to have FNAC, and if you have any doubt, please remove it. With Bethesda 4, remove it. If there is a 3 with some positive biomarkers, remove it, but it doesn't mean that everything has to be operated. The non-surgical approaches are iodine supplementation, thyroxine therapy, radioactive iodine, percutaneous ethanol injection, and laser ablation. In the days gone by when iodine deficiency was the norm rather than exception, iodine supplementation had some role. Our country theoretically is iodine sufficient, therefore it does not have any role for reduction of a nodule. So what we are left with are levothyroxine therapy, radioactive iodine, and the local techniques. One might say here that, like surgery, some of these are not available at all centers, and they are also dependent on the performance of the person who does it. It's not that everybody does it very well. Levothyroxine therapy was initially considered to be very, very important therapy, and there were a lot of trials which showed that it does cause the regression of the thyroid tissue. Unfortunately, it reduces only the normal tissue between the nodules, and again, iodine deficiency is one situation where this is going to work. But one must be also considering the fact that if you suppress TSH too much, you can cause bad effects on the bone as also on the heart tissue. This is a summary slide of various trials which show that most of the trials except one have caused some regression. There is only one trial which definitely showed a definite regression without the confidence intervals being ambiguous. But if you look at it, though there is a net difference of slight reduction in the goiter size or the thyroid volume, it is not very significant. So it is not considered as a therapy for treatment for these patients. These guidelines say that it is not recommended, except in areas where there is iodine deficiency, or obviously there is hypothyroidism and the patient is going to anyway receive this treatment. If the patient has had surgery in the past, it is again not recommended if the TSH is normal to prevent new nodules from being formed. Then coming to radioactive iodine, it obviously is going to be useful if there is an uptake of iodine by the gland. If there is no uptake or heterogeneous uptake, then it is not going to work, because for it to work, it has to be incorporated into thyrocytes and then or into the colloid, and then it's going to cause destruction of thyrocytes. So if the patient has a prior thyroidectomy, it is possibly better to do this rather than do surgery. If the goiter is moderate in size, it is important to do it. Obviously, patients with comorbidities, it is the treatment of choice. Whenever there is suspicion of malignancy, obviously surgery is better. If you got very large goiters, like you got a volume of something like 10 cubic centimeters, then it is probably better to go for surgery. People feel that if there is a compression and the compression is significant, it is possibly better to do surgery, though a tumor regression or a nodule regression can also happen with radioactive iodine, and that's not an absolute contraindication even in retrostomal goiters. But uptake being very, very low, the therapy does not succeed. So people have thought of combining this with recombinant TSH, which is obviously going to double the uptake of iodine and then make the therapy more effective. And then it can cause reduction in the volume by about 30 to 50%. It's particularly very useful in patients who have got very large goiters, who have got comorbidities, and whenever you give it with TSH, obviously you are going to have a higher incidence of hypothyroidism, and this treatment is of course exciting, but it is off-label. This is a graph or cartoon showing you the change in the thyroid volume after giving TSH and without giving TSH. You look at the lines which are there for TSH, you find that the volume reduction is much more with TSH in place. This is a very simple slide which shows you the reduction with various series, and you can see that the average reduction is about 30 to 50%. The guidelines also say that the nodules need to be treated, but a routine TSH suppression in iodine sufficient population is not recommended. Individual patients, it may be, if you have some suspicion of iodine insufficiency, you may give them iodine. But more and more, if you have a nodule, then you have to go for local treatment. And the local treatment is that when you inject ethanol, it causes coagulative necrosis and thrombosis of the small intranodular blood vessels. Best results obviously will be seen in cystic nodules. And there can be some problems apart from pain. If you have got seepage outside nodule, that can lead to local pain, swelling, and sometimes recurrent damage also. But the ACE guidelines say that it is a very safe and effective procedure for cis complex nodules with a large fluid component. It can also be considered for hot nodules when other treatments are not possible, but it can be certainly of use in patients who have relapsing cystic lesions. You also have the possibility of laser ablation instead of injecting ethanol there. This is also an outpatient procedure, and you deliver some laser through a diode, and it is quite effective as a single procedure with a reduction in the volume of slightly more than 50%. There are no long-term influence on thyroid functions. Radiofrequency ablation is also a choice wherein you put some thermal injury in nodule with high frequency alternating current. The reduction in the size of the nodules and also cosmetic scores has been seen, and it is as effective as laser ablation. The ACE guidelines support that if you are considering this, like we said in the beginning, you have to be sure that you are not having any malignancy in place, and if there is some such consideration, please do not offer this therapy. So if one has a cystic nodule, then one should go for ethanol injection. So toxic nodule, that is obviously the best condition to be treated by radioactive iodine. Toxic multinodular goiter, again plain radioactive iodine is going to work. But if you have got a benign multinodular goiter, which is non-toxic, you might give radioactive iodine, and addition of the recombinant TSH is going to be helpful. The key points then are, majority of thyroid nodules being benign, they do not require surgery. The choice is between leaving them alone as such or offering them something which is not surgery. Before we consider anything like conservative treatment, leaving them alone, or doing whatever I said, one has to exclude malignancy. The choice of therapy will depend on the morphology of the nodule. As I said, if it's cystic or predominantly cystic, then you can go for ethanol injection or laser treatment, radiofrequency ablation. If it's functional, possibly radioactive iodine alone. And also available expertise. All hospitals, including major hospitals in my city, do not have the possibility of a radiofrequency ablation or a laser. And finally, the patient tries, if the patient says that I want surgery, I think we should not be the ones who can discourage. We can tell the people that you can have problems with surgery, and surgery might get rid of the nodule, but if it is not done appropriately and if the gland is large, you can have injury to the retinal nerve, you can have injury to the parathyroid, and have difficulties. So there is a ray of hope for patients who are wanting treatment, and we know now after the demonetization that even small change is important, and those of you or those of us who were there on the 8th of November like me in Tirupati, I had a hard time coming back to Hyderabad because the small change was not there. So this, I am reminded of this novel which I have not read, but some of you might have read this book, and Who Has Moved My Cheese? When I was a student, I used to think that all thyroids have to be operated. But thanks to people like Dr. Murthy, who is with my teacher, and he is sitting there listening to my mistakes, we have been able to move the cheese away from the silence table onto ours. Thank you very much for your patience.
Thank you, sir. The talk is for questions.
Sir, I have known that this is done for some people, but this is not mentioned in great detail in literature. Thank you for the information on that.
Is it useful or not?
I have not read about it, so I don't think that we can recommend it for all patients.
So, what would be the cost for using recombinant TSH, sir?
Yes, you are right. If cost is one consideration, then recombinant TSH is as expensive, and as expensive as surgery. But we are looking at, let's say, purely science, that you are trying to avoid the risk of anesthesia, the risk of surgery, and then you have 50% reduction in the volume. Obviously, this is used in the area of radioactive iodine uptake following cancer surgery for thyroid. But this is an active area which can be considered, but it is expensive.
Since we live in this country and poor patients can't afford it, may I know how much it is going to cost?
See, recombinant TSH is going to cost you about 35,000 rupees. And this has to be done 1 to 2 days after, because you want to have activation of the transporter, and then you want to give radioactive iodine. But I might also warn you that we are living obviously in the same country and the same state of Telangana is far more impoverished than Chennai. Then we can also offer the patient therapy, which is observation, that you don't do any therapy if it is not in an uncomfortable area which is causing pressure. There is no harm in not doing anything. So I said there are 3 pathways here: doing nothing, doing surgery, or doing something in between, the PV Narasimha pathway, and I am treading that pathway.
Thank you.
Sir, regarding this levothyroxine suppressive therapy, what is the limit of cases that we usually titrate? Like the lower limit or the upper limit?
No, it should not be given. It is of no use. It is a
in iron deficient populations which you talk about.
Then I think you should not look for TSH suppression, because most of these people are likely to be above 40 or 50, where the possibilities of atrial fibrillation and also osteoporosis is quite high. This should not be done. But if you have got somebody whose TSH is marginally elevated, you want to give the patient the benefit, you might be therapeutic dose. Do not look for suppression.
In case of patients like post radiotherapy, as part of replacement.
Obviously, if the person has been rendered hypothyroid after any of the procedures or primarily hypothyroid, then you do not suppress the levels to those that you would be doing when you have treated a patient for papillary carcinoma thyroid. So you just keep it in the therapeutic range.
Think about the cost of the recombinant TSH, it's 85,000 rupees. And you can get away with a single injection and still it will be about 45,000 rupees.
Good morning, sir. I'm an endocrine surgeon at Madras Medical College here. It was a very nice talk, sir, of moving the cheese from the surgeon to the physician. I'd like to just tell you, like we've seen many cases where the first FNAC comes as benign, and still because of the size of the thyroid, we do the surgery and the post-operative HP comes as malignant. So what is your take on how frequently do you repeat your FNACs? How do you follow up your patients? Maybe the first one comes as benign. How do you follow up them? How frequently you follow up them? And have you seen cases where it has turned to malignancy maybe in the second year or third year?
I think it depends on what do you consider as an adequate FNAC. If it is ultrasound guided FNAC from a nodule that was suspicious, then the likelihood of missing that patient is very, very low. If you look at the percentages of patients who could have a malignancy with the DESTA 1 and 2, you know that it is up to 5%. So we come to a point then that what is the risk to the patient if you leave a subcentimetric thyroid malignancy alone? There are guidelines which say that less than 1 centimeter papillary thyroid cancer can be left alone, because the therapy of that of course makes you very happy, but does not change the outcome for any patient. And this is in the thyroid guideline that a patient who has got a papillary carcinoma thyroid 6 millimeters can be left alone. These are guidelines, this is not my opinion.
So the patient gets frequently reviewed at least yearly once by FNAC? When you see
if the FNAC was Bethesda 1 and 2, that patient can be left alone. If it was 3 or 4, you can do biomarkers. And obviously these are grey zone areas, and it depends on whether you are able to follow up your patient or not. More often than not, one can then recommend surgery for the Bethesda class 4, stage 4.
And cost of RH-TSH, like last week we asked for a patient of ours, it was 96,000. The Genzyme Sanofi gives it for 96 to 97,000. There are 2 doses.
So Chennai is obviously more expensive. Send them to Hyderabad.
Thank you, sir.
Thank you.